Okay, students, today we have topic of Dentigerous Cyst. So, starting with the topic Dentigerous Cyst. So, it is a cyst that always surrounds the crown of an impacted tooth. If you miss this on exam, it's a common trap. So, we have to know where a Dentigerous cyst mostly occurs. So, coming to the point why this matters. So students often confuse this test with other jaw lesions like AOT. The key exam point is the crown is inside the cyst. The root stays outside. This is very important. Understanding this distinction saves marks. So we have to now go to the definition and overview about dentigerous cyst. A dentigerous cyst forms when fluid collects between the reduced enamel epithelium and enamel. This pushes the crown into a cystic space, while roots remain outside. Simple spatial logic, high heat for exam. So we exam must remember line is cyst is attached at the CEJ, which is our cervical margin. So I have to tell you one thing more. Where does this fluid actually come from? Honestly, we don't fully know what triggers it, but the result is consistent. The reduced enamel epithelium separate from the enamel, creating the cystic space. These cysts are commonly seen with unerupted mandibular or your maxillary third molars. Now, coming to the etiology or origin, so we have to know that these cysts are derived from reduced enamel epithelium, often seen with unerupted mandibular or maxillary third molars, your aids, sometimes maxillary cuspids, always attached at the CEJ. I have told before. Remember, the trigger for fluid accumulation, as I have told before, is unclear, but this consistent attachment is critical for your exam's question. Now, coming at the pathophysiology or mechanism. So the stepwise logic is that the REE, reduced enamel epithelium, separates from enamel. Fluid fills the space around the crown. Cyst forms with crown inside, root outside. This is an important line. Slow expansion causes corticated edges on radiograph. This flow helps you visualize why the cyst behaves the way it does. Now we have to see the clinical features of dentigerous cyst, how it actually presents. Usually asymptomatic, sometimes mild swelling or pain. Tooth arch may appear a missing tooth, often discovered incidentally on X-ray. So the exam tip you have to learn that exam learned testing asymptomatic versus the symptomatic presentation. So clinically, dentine cysts are often asymptomatic, meaning patient might not even notice them. But if they grow large or get inflamed, they can cause swelling or mild pain, and the arch may appear to be a missing a tooth. This is an exam favorite. Always check if a tooth seems absent. Now, coming to the radiographic features. On X-rays, these tests show a well-defined radiolucencies around the crown of an unerupted tooth. Edges are corticated, which indicates slow growth. Watch out for positional changes in the mandible. The tooth may move up or down, while in the maxilla it often moves upward or backward. This special movement helps you distinguish it from similar lesions like AOT. So just keep these things in mind that what is the position of tooth in mandible and in maxilla. Now we have to look the histopath of this cyst, which is that under the microscope The cyst is lined by 2 to 10 layers of non-keratinized stratified squamous epithelium. If inflamed, this lining may become hyperplastic, atrophic, or ulcerated. Occasionally, you will see rusted bodies, crystalline deposit, and mucous cells, which are interesting but less critical. Long-standing cysts may even show keratinization or dysplastic changes, which is why careful treatment actually matters in this case. So, and key idea we should note that the crown position plus corticated margins, that is an exam anchor. Now coming to the management or treatment of Dentigerous cyst is surgical enucleation is the standard. Molar teeth usually extracted with the cyst. Maxillary cuspids cyst may be marsupialized, tooth guided with orthodontics. Recurrence is rare. Rarely, cyst may turn into ameloblastoma or carcinoma, requiring aggressive surgery. So that's how we manage a patient having a dentigerous cyst. But we have to remember if the cyst develops into a neoplasm like ameloblastoma or mucoepidermoid carcinoma, more aggressive surgery is needed. Now we got a clinical scenario here, which basically says a patient has an unerupted. Oh no, a 22-year-old patient has a missing mandibular third molar. Radiograph shows a well-defined radiolucency around the crown of an impacted tooth attached at the CAJ. So the key takeaway from here is that it is attached at the CAJ and the radiolucency is well defined around the crown, okay, and I'm missing mandibular third molar. So I've told that it occurs in your eighth. So the key takeaway we should always remember is that the crown is inside the cyst, root is outside, attached at CAJ, slow growing corticoid radiographic margins. Remember these 3 points, get these right, you will never confuse with AOT. Now, so that was from today. For more, see Neville, Schiffer, and contemporary or pathology references. If you want to learn exactly how to distinguish integers from AT, you can just subscribe and just ask in the comments, and I will help you. And I hope this video might have helped you in making building conceptual understanding, not rote memorization. And I just highlighted exam yield points. So this was from today. I hope it helped you, and you will definitely subscribe it as it will motivate me, and I will keep making more and more videos. Thank you very much and keep watching our videos. So that was from today.